coming, so possible to start or waiting 1 minute or 2 minutes? I don't know exactly. Yeah, okay, 1 minute more. You use a laptop? Or, so, could you prepare? This one is, you're first. Yeah, yeah, it's a brand. I have no paper, but maybe. Okay, prepare, and 1 minute later, we will start this session.
Email that I have to have a video on the interrupted arch with the subaortic stenosis. So now it's not with me right now. It's way back in Delhi. So I'll just make a presentation on that. So video is not there. I'm sorry for that.
Okay. Anyways, thank you very much for attending this session. So in this session, we have two presentations. Professor Taura and Sachin is the family name. Taura? Taura is the family.
Third name is Talwar and the first name is Sachin.
Sachin. So Professor Taura will have one presentation about the interruption and the subaortic stenosis. And I will make another presentation of the aortic valve repair in neonatal period. Yeah, anyway, yeah. So one is coming. Oh, could you start? Yeah, could you start? Okay.
Can you give me a pointer, please? Thank you. So it's a very important topic in congenital heart surgery, and it's one of the difficult things to manage. So first of all, I'll classify the interrupted arch. Now, it could be the type 1, when it is distal to the left subclavian artery. Then if it is between the, I'm sorry, I have a bad throat. If it is between the common carotid and the subclavian, it is type B. And then the type C is proximal to the left common carotid artery, and the type B is the most common. Now, the associated lesions are very important. It's very rare to find the aortic arch interrupted along without the congenital anomalies. The important thing is the survival depends on the PDA. So once the PDA starts to close, these patients have a severe low cardiac output state. So multiple VSDs are found in almost 3% of the patients. But the important thing is the LVOT is in 10%, 16% of the patients, and the valvular aortic stenosis in 10.5% of the patients. And these babies are often syndromic. So the left ventricular outflow tract obstruction, even if it is not present at the echocardiography when you try and assess them, and then you repair the interrupted aortic arch, the LVO2 can appear in as more as 50% of the patients with the ventricular septal defect. And clinically important LVOTO, whether it is at the valvular level or whether it is the sub-aortic level, so a Doppler acceleration of 3 meters per second or more will render this LVOTO significant, and that will require some form of intervention. So this LVOT obstruction of interrupted arch, the commonest type is a subaortic stenosis. One of the reasons for that is patients who have got the interrupted arch often have the posterior deviation of the conal septum, and this can morphologically cause the subaortic stenosis, and this has implications of in the repair of these patients, where when you close the VSD, it is not only the size of the patch, but it is also the orientation of the patch. It makes it important to relieve the subaortic obstruction. So posterior deviation of the infundibular septum can lead to increased turbulent flow and increased proliferation of fibrous tissue. And that is one of the reasons for the subaortic stenosis. And it can cause obstruction at the valvular and the subvalvular levels. The prominent muscle of Mullard is again an important thing. A small aortic annulus, a bicuspid or dysplastic aortic valve, and then the subvalvular stenosis is much more common in patients who have got these tricuspid aortic valves. The So the risk factors for development of interrupted aortic arch are age, then body weight, location of the VSD, and the type B interrupted aortic arch, the aortic annulus Z-scores of 3 or less, and the bicuspid aortic valve. So if the aortic annulus score is Z-score -3 or less and bicuspid aortic valve is there, then the chances are that you go on to have an interrupted arch. And obviously the age and the weight are important factors. Now, what are the predictors of LVOT? An absolute diameter of the aortic valve annulus less than 4.5 millimeters, and the Z-score less than 5 completely predicts the development of LVOT obstruction. So if you have a Z-score of -3, you may get an interrupted arch. But if it is less than -5, definitely you're going to get a subaortic obstruction, whereas the size of the aortic region is narrow or not. Now, this is an important paper, and this discusses the same thing in the amount of the Z-scores, which is essential for the development of subaortic stenosis. And this is a paper from Richard Van Praag, and he has studied the morphology of the LVOTO and the interrupted arch in many patients. And he has also given this concept that the deviation of the conal septum as well as the Z-scores of the aortic valve less than -3 will definitely lead to the subaortic obstruction in these patients. And this is the cartoon which shows that the conal septum is deviated posteriorly, and this is the ascending aorta, and you see that the aorta is also hypoplastic, and then this is the patent arterial duct which is feeding the PDA. So this is an example of a type B obstruction in which the displacement of the conal septum has produced the subaortic stenosis. And this is the echocardiography, the parasternal long axis view, and it shows again the posterior displacement of the conal septum, and this is the level of the obstruction. The subaortic obstruction is very prominent in these patients. So the aim of surgery for these patients is to decrease the overall need for the LVOT operation, because that can have the implications in the postoperative phase. The prolong the interval to LVOT reoperation, because many of these patients will require reoperation. So you prolong the period of the first operation to the second operation, then reduce the complexity of the LVOT operation, because these patients are often very small and the operations become more difficult, and to reduce the risk of mortality after the LVOT operation. So morbidity is significant, the mortality is significant, so you want to do things which will reduce the mortality and reduce the morbidity also. So there are two types of repair. One could be a two-stage repair, like you just manage the arch and do not do anything to the VSD or the associated anomalies, because that will again make the operation very complex, and some will advocate a lower mortality with primary operation. But the others have said that the mortality can be as high as 31%, but it can be reduced to 19% with a single stage. Now, currently, the optimal timing of surgery is within the first week of life to prevent the pulmonary circulation, and the techniques which are employed to repair the interrupted arch could be a direct anastomosis between the ascending and the descending aorta, because the neonate is very easy to mobilize the aorta. Then there could be a direct anastomosis with the patch augmentation, and sometimes in the older patients, they might need a conduit interposition. In the last week, I did a 7-year-old girl with an interrupted aortic arch and an aortopulmonary window. So we had no option but go from the midline, go on suck arrest, and we placed an 18-millimeter graft, an end-to-end graft, which is enough for her, because 20 kilograms and 18 grafts will last for the rest of the life. But there was absolutely no option, because the aorta was not easy to mobilize. So the interrupted arch associated with the subaortic stenosis, you could do a standard VSD closure and ignore the subaortic stenosis and deal with it if it becomes important at later stage, or you create a double out left ventricle and do an aortopulmonary anastomosis. The VSD is directed towards the pulmonary valve. The MPA is anastomosed to the aorta. It partly augments the aorta. So via the VSD, the left ventricle is directed to the aorta, and then the distal PA stump is closed, and then the right ventricle to the pulmonary artery continuity is maintained by the use of an interposition graft. Now, this is can also be called as Norwood with Rastelli, and this was first described by Dr. Yasui. Now, the other problem is the other solution is if you do not have the VSD which is routable to the aorta, then you have no option other than go for a single ventricle pathway. You resect the coronal septum and put a patch to the leftward aspect of the ventricular septal defect, because that enlarges the area of the subaortic stenosis, and then later on these patients can come on to have the various stages of the single ventricle. Now, initially, you do a PA band to reduce the QP, and then progress to Glenn and Fontaine as for the Norwood strategies. You go at 6 to 8 months for a Glenn, and then around after 2 years, you go for a Fontaine. The problems are that the band can migrate, and sometimes the band can aggravate the subaortic stenosis. So then you have to tackle that. So the other school of thought would argue that you do the Norwood operation, because the Norwood type of operation can take care of all the levels of the obstruction. It can take care of the subaortic tissue, and it can take care of the valvular level, and all the levels at the level of the arch. So with the Norwood operation, all of these can be eliminated. Then if you close the VSD without the resection, the thing is to use a small VSD patch. Because if you put a large VSD patch, it is going to bulge into the left ventricular outflow tract. It's going to aggravate the subaortic stenosis, and the cephaloid end of the patch is placed on the left side of the coronal septum and is used to pull the coronal septum anteriorly. Once the coronal septum is pulled anteriorly, then you find that it elevates the left ventricular outflow tract. So your chances of getting severe subaortic stenosis are much lower, and also it has the advantage of leaving the coronal septum, coronal muscle, to anchor the patch to the cephalic. So you have the patches, the infundibulum is now it is pulled up anteriorly, and it is pulled up in a cephaloid direction. So you enlarge the subaortic stenosis, and this is the picture which shows that you open the pulmonary artery, and from here also you can do the closure of the VSD and then repair the interrupted aortic arch. This is again a picture in which the pulmonary artery is open and the incision is extended up to the ventricle, and from here you direct the VSD towards the pulmonary valve, and then you would go on to make an anastomosis between the pulmonary artery and the aorta, and then address this with a right ventricle to pulmonary artery. And this shows that the patch is sutured to the left side of the septum, and once you do that, you not only pull the infundibulum septum superiorly, but also pull it inferiorly, and that enlarges the subaortic region. Now, all this then can be done from the right atrium, from the transpulmonary approach, from the transventricular approach, or the trans-aortic approach. And this is the picture which shows that you're looking from the right atrium, you elevate the tricuspid valve, and then you resect in such a way here so that your VSD gets enlarged. And this, you can see that the coronal septum has been enlarged in this direction, and then the VSD is closed, bringing it towards the left side of the coronal septum. So Yasui procedure is a very important procedure in these patients. So what, again, you do a Demus case stencil type of the anastomosis to take of the LVOT. The blood then flows via the left ventricle into the main pulmonary artery through a VSD patch, and then to give the flow into the pulmonary arteries, use a Rastelli type of an operation. You can use a homograph or something else. And these are the steps of the Yasui operation. You've done a ventriculotomy, and then the VSD is closed to direct it towards the pulmonary valve. And many times you will need to use a graft or something. You might need a Dacron graft or the Hema shield, and then you direct the VSD towards the main pulmonary artery. The arch is then repaired completely, and the arch has been repaired, and you will see here that the main pulmonary artery proximal has been sutured to the aorta. The aorta has been augmented, the arch has been repaired, the VSD gets the flow into the aorta, and then you take a valved homograft and do a right ventricle to pulmonary artery anastomosis. So at all levels, this is repaired. The other thing is a LVOT bypass. The advantage is that you restore the normal physiology of a circulation in series, you eliminate the prolonged sinuses and volume load, and then you potentially reduce the number of operations, and you have the reduced cost. So two-stage approach. The first stage is a Norwood type of operation, and second stage is the Rastelli type thing like we discussed in the last stage. So first stage, just do the Norwood operation and limit it to the Norwood part. And at the second stage, go ahead and complete the Rastelli, because this minimizes the morbidity of cuts down your clamp time and the bypass time. And in small babies, it prevents operation at the level of the ventricle. Now, the advantages of this are, again, you avoid a complex intracardiac repair, and as a child grows up, your chances of putting up a larger conduit will become more, so that will reduce the incidence of reoperations. Because if you do this operation in a neonate and you end up putting a graft that's 8 or 10 size, within 6 months the baby is going to require reoperation. So if you postpone the conduit to a later stage, then you can put in a larger stage homograft. However, the disadvantages are that you can sometimes have the neo-aortic valve regurgitation and the ventricular dysfunction, especially if you try to bypass the LVOT, and that has its own problems. Now, a paper from the Congenital Heart Surgeons Society has addressed this very well in almost 500 patients, and it was found that the mortality predictors were the lower birth weight, the younger age at repair, the type B interruption, the outlet and trabecular VSD locations, because it will be difficult to direct all these VSDs to the pulmonary valve, the smaller size of the VSD, because this would entail the enlargement of the VSD and a risk of the heart block, and the presence of the subaortic stenosis. So it is to be understood that at all levels a procedure has to be undertaken. And the Z-score of the aortic annulus significantly increased if you did not do anything to the LVOT within 1 year after the primary repair, both in patients with a Z-score of 3 or less, and in those patients who had a Z-score of 3 or more. So it is important to understand that mere relief of the intraepidurals close of the VSD does not guarantee that the subaortic stenosis is going to go down. The freedom of reoperation in this Congenital Heart Surgeons Society is a large study, many centers, 500 cases. So after primary repairs, as many as 83% of the patients have a reoperation at 10 years, and 98% of them have reoperation at the age of 5 years. The freedom from operation for the arch and the hazard of the arch reoperation is characterized by the presence of an early phase of risk when the immediate phase, and that disappears at 1 year, and then late in the follow-up, they require the reoperation at another stage. So this is a sort of a guideline paper, again, from the CHSS, and it gives the guidelines, and the preferred approach is do a standard approach in those patients who have got the LVOT diameter of more than 4.5 millimeter, and LVOT bypass if the Z-score is less than 4 or 4.5. So with this approach, the survival is 8 years. At the 8 years, it is around 87%, and reoperation continues to be a problem in 20 to 40% of the patients. And the interventions are required for restenosis of the aortic arch, for the branch pulmonary artery stenosis, for bronchial compression, because you mobilized the aorta to repair the aortic arch, and recurrent subaortic stenosis as there is a gradual development of the fibrosis. And then the ways you can deal with the LVOT is do a modified Kono procedure, do the Ross Kono procedure, do an aortic valve replacement along with the Kono procedure, and then the complex relief procedures for the LVOT, and again go back to the Damaske stem cell LVOT bypass procedures. So take-home messages from this presentation are that the heterogeneity of the LVOT obstructions mandates the individual management as per the anatomy, and then the morphometry should be used before surgery to diagnose hemodynamically significant LVOT obstruction when there may be little or no gradient pre-operatively, and it may appear post-operatively. The Congenital Heart Surgeons Society has developed a calculator, that is the CHSS calculator, and if you feed in the values, many of the values of the aortic valve Z-scores, the arch, the aorta and all that, it can give you the predictability of whether the patient should be taken on the biventricular pathway, or whether the patient should be taken on a single ventricle path to eliminate the reoperations. Now, it is very important to realize that if patients are being taken on a single ventricular pathway, then the VSD should be enlarged as much as possible, because the debate is always between a pulmonary artery band and the VSD enlargement. So if you enlarge the VSD, then you have more relief of the subaortic obstruction. On the other hand, if you do a pulmonary artery banding, the subaortic stenosis can progress and it can lead to multiple reoperations. The disadvantage of this approach when you do an enlargement of the VSD is the risk of development of the complete heart block. But if you enlarge the VSD in an enterosuperior direction towards the pulmonary valve, then the chances of getting a heart block become minimized. So thank you very much for your attention. And I would again request you to mark your dates for September 17th to 20th for the 7th scientific meeting of the World Society of Pediatric and Congenital Heart Surgery, along with the Pediatric Cardiac Society of India. Thank you very much.
Thank you, Professor Sachin. That's a very beautiful presentation together with informative, many information. So we would like to open the discussion. Oh, yeah.
Dr. Talwar, excellent presentation. As we all know, there are tons of definition for left ventricular outflow tract obstruction, and every single paper, probably between 15 to 20 different definition of what is how small is small and what is the left ventricular outflow tract obstruction. That is a problem, but I think what I personally use is weight plus 1.5.
Yep.
And if you have like 4.5 millimeter,
yep,
the likelihood of an obstruction is probably nil, but less than that, always be worried. And 1 millimeter may be worried, but anything less than 1 millimeter,
yes,
you will end up almost 100% obstruction, yep, and then you should plan your operation at the beginning.
Yes.
Planning that obstruction may be going different ways.
Yes, I do agree that weight plus 1 or 1.5 gives you a good degree of idea, because many times what happens is your preoperative echo does not tell you that, because the blood is flowing in, from various things. But the moment you you do the arch repair and all that, this stenosis becomes more significant. So if on the pre-op echo, you find that, as you have mentioned, the weight plus 1 is there. And the other thing to see is if there is a flow acceleration, which is more than 3 meters per second, that predicts your development of LVOT obstruction very commonly. And if you see that the VSD is placed in such a way that it is probably after you pull up this VSD and towards the left side of the coronal septum. So if that picture comes into your mind, then you're going to get the LVOT obstruction. So might as well fix the VSD at that setting. Otherwise, there's a problem. And this is also a problem when you decide between the single ventricle path and the biventricular repair. Many of us would do the arch repair and think that we place the pulmonary artery band and then take care of the VSD later on, or put the patients on the single ventricle pathway. So what invariably happens is you do a band, because the baby is sick, you want to postpone the primary repair, but that placement of a band, it increases the subaortic stenosis. And so then the backup plan at the next stage is to take off the band and that enlarge the VSD, and that can become very messy. And then you may be forced to do a ASCVTS type of operation, when you may be forced to direct the return from the LV via the VSD into the aorta, and it can really be very messy, and then do an RV to PA conduit. So it has to be recognized before the operation. And you see the flows across the acceleration across the VSD, and as you said, use that particular formula. And this Congenital Heart Society has a calculator, and you can feed the various values about the LVOT and aortic arch and all those things, and then you get a probability of being able to achieve a biventricular repair or on the single ventricle path, and that you can use as a guideline to plan your surgical strategy.
Do you have another? So go ahead.
Thank you, Sachin. Very excellent take-home message like that, morphometric evaluation with the advent of the diagnostic measures such as and MRI,
Yeah.
would you take that into considerations into your pre-op evaluations? I just like to also, Sabu, comment what's in your place there. Thank you.
The advent of the MRI has made this assessment very easy. The problem with the MRI in small babies is that you have to sedate the child and intubate the child. The acquisition times are very long. It can be 45 minutes to 1 hour, and it's very difficult for a baby to undergo that much, have that much acquisition time. So a CT angio is a very good tool, and that CT angio can be used for 3D printing. That 3D printing helps you a lot. And now there is the advent of the virtual dissection. So if you do have a virtual dissection, you can very reliably tell what is the nature of the obstruction and which path you should take the patient on. The technology is available. It's not available everywhere, but it costs money also. But the diagnosis can be very accurate.
Yeah, let's go.
I'm from Taiwan. In my experience, the VSD with IA have two possibilities. One is type 1 VSD and the other is type 2 VSD with posterior alignment. Did you find the difference between the instance or your management between these two kinds of VSD in terms of the ventricular outflow obstruction?
I'm sorry, I don't understand the type 1 VSD and the type 2 VSD.
Type 1 means there is the subarterial type VSD.
Okay.
And the type 2 is perimembranous VSD.
All right. So the perimembranous VSD will be difficult to route to the pulmonary artery. So then the chances are that you would not be able to do a SUV type of operation. So if you just have a VSD that is a pure perimembranous type of VSD and has an inlet extension or a muscular VSD, you just cannot go to the pulmonary artery. So then you have to choose some other method of repair. So these patients are likely to go along the pathway of the single ventricle because the subaortic stenosis will be difficult to resect in such a small baby. So the type 2 VSD you said was? Type 1 what? Subarterial VSD, yeah. So if the VSD is subaortic, again you have a problem because the subaortic VSD is below, lying just below the aortic valve, and the area in the aortic valve may be stenosed and the ascending aorta might be hypoplastic. So the routing of the VSD to the aorta does not help. So you need to have a VSD which can be routed to the pulmonary artery because the pulmonary artery will be required to augment the ascending aorta. So, and failure to augment the ascending aorta at the time of routing the VSD is definitely going to lead to the subaortic stenosis. So the current approaches to management of these patients are you take a small patch, route the VSD to the pulmonary artery, and often that patch, as you saw in the diagram, needs to be small. So that once it is small and towards the left side, it pulls up the coronal septum and you have relief of the pulmonary stenosis. So perimembranous with inlet extension and the subaortic VSDs are bad substrates for these patients. Yeah, it helps very much. Yeah, 3D is phenomenal, and nowadays the virtual dissection is coming up. So although like everybody is not familiar with the virtual dissection, but I have seen 2 or 3 patients because one of the persons at our hospital is working on the virtual dissection. There's a software for this which is available free of cost from online. You can go and get that software free and then feed the data of the CT angio into that software, and it gives you beautiful images. It's almost like you're walking inside the heart, and that helps you predict the level of obstruction and plan your management. We'll keep that in the World Society to keep you interested.
Yeah. Anyway, so sizing of the
Actually,
small diameter.
Bob Anderson is working in collaboration with that person in our institute, and both of them are now working very aggressively on the virtual dissection.
Okay, so measuring the very small size is difficult by even echo by CT and MRI. So, and I have one question. So, interruption of ventricular septal defect, perimembranous, and if the patient has the exact borderline 4.5, you do aggressive, usual simple biventricular repair or Dubs case answer?
I think the most important thing to see is that at the end of the repair of the VSD,
I know.
LVOT should not be obstructed.
But your comment is before.
Yeah.
Before we have to decide which way.
Before you, in borderline patients, often you will end up
just the borderline.
You end up taking a decision on the table. we are ability to route the ASD towards the pulmonary valve. Because aortic valve doesn't make sense.
So our Japanese approach is during the operation, sometimes I do make a bilateral banding.
Yeah.
And to increase the antegrade flow to the ascending aorta and check the echo together with before banding and after banding. If the size of the LVOT and ascending aortic acceleration is changed, we consider again.
If you have more than 3 meters per second square estimation, then you're going to land up with severe subaortic stenosis. So often, even in patients where the VSD is subpulmonary,
so pulmonary is difficult to
extending toward, even in those patients where your VSD is subaortic and extending into the pulmonary area or purely pulmonary, you need to do a resection of the LVOT. You need to resect a wedge. Otherwise, that is going to produce an acceleration at that level. And obviously, there are no good options trying to redirect them to the aortic valve, because the aortic valve most of the time is normal.
You're right.
So you are using the ascending aorta just to pursue the coronaries.
Of course. Even using the advanced technology, it's not so easy to make exact decision before operation. I think so.
These patients are one of the most difficult patients to manage. Thank you very much. My phone, please.
Last presentation today.
You get more time for presentation. Shoot your own time.
Okay. Hola. Is it okay? No? Connecting? Oh, yeah. Oh, this is finished. Last one, that's one. Okay. My presentation is aortic valve repair in newborns. No conflict of interest. As you know well, characteristics of the atrioventricular valve in newborn: small, size and age, no effective small artificial valve, as you know well. So anxiety of the future reoperation after valve replacement using annual arrangement technique. But so on the newborn, we cannot make a corner procedure usually. And technically demanding, including neonatal loss. So usually, many institutes informed us about more than 20 to 30% mortality within 1 year after loss procedure. Some institutes informed, very good result, totally generally, very high risk operation of the neonatal loss. And the growth potential 3 times during the 1 year after birth. Rapid degeneration of the foreign materials, sometimes pericardium, pressure autologous pericardium, and others. Difficult to control on anticoagulation management because of common cold on the neonatal and the very infertile period at that time. So baby cannot get the exact warfarin on others. Anyway, Professor Lasker informed us about the result of the open valvotomy for critical aortic stenosis. If the patient has 3 cusp morphology at the time, long-term result good. However, if the patient has 1 or 2 cusp morphology at the time, like that, one commissure and another one, bicuspid or unicuspid, at the time, result was worse than 3 cusp group. Anyway, this slide shows the commissure morphology. Normally developed like that, commissure, coaptation height higher are acceptable. Like that, even the aortic valve has bicuspid. If this commissure coaptation height is higher, larger, it's okay. However, underdeveloped, lower, laughing, almost nothing. So, if we do choose balloon balloon aortoplasty at the time, cutting, not on commissure. So regurgitation is coming. Valvotomy is better to make a better result. However, this one is good, together with not reasonable but acceptable height of coaptation, but this LVOT, or no coaptation height, so after cut off the commissure or LVOT, the valve will have a massive regurgitation. Today, I show three types of the neonatal aortic valve. This one is two bicuspid and rather good form. This one, yeah, 2.1 kilogram, 29 days. And the aortic valve ring is 6 millimeter or so, pressure gradient 80 by echo, like that. You can see this one. Commissure, better side, better coaptation height side. We can commissurotomy to wall. And maybe this commissure will not have a regurgitation because of the acceptable coaptation height. However, another side, you can see this side. The coaptation height lower, smaller than the other. So I was afraid to make a regurgitation. So before 0.5 to 1 millimeter, I stopped the commissurotomy. However, anyway, you can watch the small regurgitation here, this side. Just okay. So this patient had the pressure gradient is around 30 to 40, together with slight regurgitation. And this patient can, even now, can keep the aortic valve condition within less than 40 millimeter mercury and slight to mild regurgitation. Now, he is 5 to 6 years old. And another one, this one. One, acceptable, almost normally developed commissure, and one LVOT, so-called unicuspid form. You can see this one, very clear, one commissure. No other commissure are there. And this one is not neonate, 76 days, 3 point larger. Aortic valve ring also 8 or 9, so not so small. And this one, you can see, oh, this one, oh, no, coaptation height, just LVOT. What kind of approach do we have? So for this patient with no coaptation height on at LVOT, I do make her commissuroplasty using a pericardium patching. And so 2 years ago, I have reported this technique, open sleeve technique in Europe. I cut open the ascending aorta to planned commissure side. This is a sleeve of aortic valve. And to make this commissuroplasty, sometimes one patch, sometimes two patch. On this patient, I cut open here. Yeah, stitch is 8-0, monofilament. And the pericardium, 3 minutes tanning. Yeah, very simple, right? So because to make a neonatal aortic valvoplasty, sometimes we have a difficulty to make exact detailed stitch, meticulous stitch, because of the size of the ascending aorta opening. So together with this open sleeve technique, we can make a better operative field to make a meticulous and detailed procedures. You can see 8-0 to make a little larger deflect. Anyway, I did make a 2 like that. And finally, and adjust the leaflet rings like that. It's not so too difficult because together with open sleeve technique. So usually, so without disc cutting, many surgeons had the difficulty to make inside the small ascending aorta, but this technique is better to make a better operation. You can see. Anyway, so close this one. Oh, this patient had reasonable ascending also reasonable acceleration within 2.5 and no regurgitation. And this patient had passed around 3 years now, and no regurgitation, and the pressure grade is a little bit increasing, 3 to 3.5 now. So maybe, or and I don't know exactly, so the patient have a possibility to have a reoperation on here. I don't know exactly when. Anyway, this is a report of the in the Europe open sleeve technique. This is the sleeve of the ascending aorta. The third one is no cuspid or very underdeveloped aorta. So this patient had have been diagnosed fatal period, severe aortic stenosis and regurgitation. Yeah, this one is a fatal echo. Oh, this one is S and R. So we thought this patient would have hydrops and die. However, this patient could get a bus, and PDA ligation was made on 7th day. Even after that, the aortic valve condition is severe stenosis and severe regurgitation. So the patient could not keep the circulatory condition. So I do make her operation day 21 first and around 2.0 kilo. Ascending aorta was huge because of stenosis and regurgitation. And this valve, yeah, I try to cut open the maybe commissure, but the valve condition is very bad, almost dysplastic short rings. So during operation, before operation, I did prepare the cusp extension or cusp reconstruction technique. So finally, I did decide to reject the ascending aorta cusp like that and make her leaflet reconstruction, like her Ozaki procedure, like her Boston trial. But these three are very small patients. So Boston also have a very less experience on neonate to make her a leaflet reconstruction. So this one is the pericardium. And the form is like that. I do make this one, not Ozaki type template. So this is my template. Anyway, so I did make her 2 cusp reconstruction. So I used this template 1.5 times of the 3 cusp form. And this one is a little bit larger than expected. So, and usually after reconstruction, cusp, I adjust the cusp form together with the central stitch or peripheral stitch and others. Anyway, yeah, you can see another side I do make. And this area, I had a difficulty to make exact coaptation between the facing leaflet. So I decided to use here open sleeve, not completely, open and reconstruct to make a better form of coaptation of the facing leaflet. Yeah? Anyway, I do make. So a little larger leaflet. So I did make plication of the peripheral And finally, central application to make not natural, but Arantius body. Anyway, this patient had very good result together with large opening, but a little bit longer leaflet than expected on myself, but no stenosis, no regurgitation. And this patient had exhibition on post-operative second day, and total ICU stay 4 days, and discharge from the hospital 36 days. And after that, the patient can grow reasonably, acceptably, without no other hospitalization till 24 months. So she is now 2 years old. Anyway, so within 20 years, I had 170 procedure on aortic valve, and 69 patients on the aortic valvoplasty. A systemic aortic valve, including hyperpractic rest syndrome, sometimes for single ventricular physiology or with hyperpractic rest syndrome, I sometimes try to make an aortic valve opening. So, and among the 6 patients, 1 had rate this. So, and the commission number and the leaflet number, 1, 2, 3, 4. 3 is most, but 3 group has the aortic regurgitation group. So percent survival is good. So it's usual. And freedom formulation is 15 years, at 15 years, 61%. Freedom for every year, almost same. Not so good, totally, generally. So it's better to check systemic outwards. Oh, I got, so a 3 cast group and 2 cast or 1 cast group is almost same, together with decreased extension and others. And this one, the freedom reoperation on the patient with additional patch, no and yes. Nothing particular significance. And more than 4 years old group, together with additional patch, more than 4 years, larger one, no mortality, and not so bad result long term. However, this one, less than 3 years old, had a worse, very worse result. How should we consider this difficult group? So I show one case, 24 days, 2 cusp reconstruction, replacement. So around 5 years ago, this patient, I had to make an operation. Second re-intervention on every valve at 9 months. And at 2 years old, less than 3 years old, I did make a condom. You can see this one. Anyway, this is not a target today, just a condom operation on 2 kilograms, 12 kilo, 2 years, 2 kilograms, using your ATS 16 millimeter in size. Yeah, cut open. This is the reconstructed aortic valve. Previously, pericardium, and cut open here, LVOT, and cusp, and yeah, anyway, that's a condom. So this is one of the late option condom procedure after aortic valve repair during neonate or very early infantile period. So this one, 4 years old group had a very good result, less than 3 years. But this group had reasonable LV function, diastolic dimension, and ejection fraction. So the group less than 3 years old could keep their reasonable growth and development, including LV size and function, without anticoagulation. They have a possibility to reach valve replacement or loss procedure late after this, not reasonable, I don't know exactly, aortic valve repair in the early infantile period. So, aortic valve, take-home message, aortic valve or systemic aortic valve repair with and without cusp extension or replacement reconstruction more than 4 years old can be performed with reasonable early and late result. Aortic valve or systemic aortic valve repair less than 3 years old has better survival rate and not so good reoperation-free rate so far. However, they could keep their reasonable body growth and left ventricular growth together with function without anticoagulation. They also have a possibility to reach later valve replacement or loss procedure with lower acceptable risk. From the point of view, aortic valve repair for neonates and early infant can be reasonable and expecting choice now. I believe so. Thank you very much for your attention. Yeah, and I would like to open the discussion. If you're having some comment or ask, yeah, please.
Thank you. I think this is a very difficult topic. And I have one question, because we know in newborn, unless there is a 3 cusp, we always need to require redo operation. And what is your timing and or your criteria to go on redo for residual aortic valve stenosis?
If the patient has 3 cusps, I do make a simple commissurotomy, like Professor Alaska.
Yeah.
And this group is very difficult to make a reasonable outcome after simple commissurotomy. Maybe it's 20% of the critical resistance has this condition. And so even Professor Alaska had the worst outcome on the patient with uni or bicuspid. That's the reason why I did make these procedures.
I know. I mean, in the follow-up period, they will debate new or aggravated aortic stenosis.
Yeah.
And what is the pressure criteria or what kind of criteria you use to go on redo? Because I frequently found that some patients have the pressure grade maybe mean 35 or around 40, but the patient maybe looks no frequent. What is the time
criteria?
Yeah.
Usually it's 50 millimeter mercury. So by echo.
But is the peak or mean?
Usually the peak.
Peak 50.
Yeah, peak 50. However, after the echo, not final diagnostic echo, together with echo, if the patient has more than 50 millimeter or 50 millimeter mercury, so 4 meter or 3.5 to 4 meter. After that, we checked again the left ventricular function, the mitral valve regurgitation and others, and the ventricular thickness. And after that, we decided to make operation. And so to make this aortic valve repair, so usually more than 5 millimeter or sometimes 6 millimeter is the reasonable target. So because 2 millimeter, 3 millimeter, but 4 millimeter is also not so easy to make. So sometimes together with open sleeve technique, we can enlarge the aortic cannulas, of course. However, so I don't have a very small one experience, so I cannot say it's good operation or not.
If the patient is dead going have a radial aortic valve stenosis, will you go on the operation or you will try the balloon dilatation of the repaired valve?
On the patient with subaortic stenosis?
No. After repair.
After repair?
Yeah.
Oh.
Will you try it? Because
I don't have experience, so.
I frequently ask the pediatric cardiologist to dilate it again, but it seems not effective.
Yes, but so on this small patient, to make a balloon just under area is not so easy to do. Maybe I don't know exactly. I have no experience.
Okay, thank you.
Nice presentation.
Thank you.
I had a small question. Like you showed a video of a 3-year-old patient in which you put the mechanical valve.
3-year-old.
I think when you putting the mechanical valve or something.
Kono?
Yeah, Kono.
Kono.
So no, my question was like if you can do the reconstruction of the aortic valve
Again?
Yeah.
Pericardium. It's
Why
also a
you
choice.
can't do it again?
Yeah, it's also a choice. But I informed all the things to the family.
Okay.
And the family decided to use a mechanical valve.
And not even a Ross procedure?
Yeah, so the patient had slight to moderate mild regurgitation on pulmonary valve.
Oh, okay. So can't it be fixed? Because
Can't
if
fix?
it cannot be repaired, then like people have described techniques of repair of the autographs also.
So
in the older patient, but it has been described.
anyway, so I informed all the factors to the family. So families decided to use a mechanical valve because he was a boy. He was a boy. Yeah, he was a boy.
And how much regurgitation you would accept after the first or the second stage?
After aortic valve repair?
Yeah, first stage or second stage, if you regurg, how much do you expect? How much
Regurgitation together with this extension or? No.
At every point of time.
Every point.
How much regurgitation do you accept?
Accept. Moderate.
Moderate.
Yeah, because simple commissurotomy can have regurgitation. So from mild to moderate sometimes.
Yeah, when I was working with Dr. Jonas, he used to always say, even whether a balloon LVOT is done, surgical is done, he would accept as least as moderate. Even in high to moderate, because he used to say, it is better to let the AR be there, because that can lead to the growth of the aortic annulus.
Yeah.
So your next reoperation will probably become easier. So that was his usual strategy.
Yeah.
He used to prefer balloon dilatation rather than a surgical.
Yeah, even our in the institute, so our cardio team try to make a balloon, but not sometimes, rarely, not small.
And how much grade need to accept?
Gradient, acceptable?
After first operation, in the interval stage.
Oh, yeah.
When do you decide to intervene?
It's same, 50.
50, okay.
Yeah.
50 is peak?
Peak, usually peak. Okay. By echo, firstly.
But
after
50 may not hurt the ventricle too much.
Not on the patient, during the follow-up period. So if the patient had more than 50 millimeter mercury, by echo at the time, we do make a catheterization, and peak to peak, using catheterization, pressure gonna more than 40 to 50. So I cannot say exact value, 35, 45, but still 40, 50. That's the target to make a repair.
My problem is different. Like you have a gradient of 50,
right?
But the ventricle is not hypertrophied.
But
because I think ventricle is going to
make overestimation sometimes.
That is okay, but as long as it is not hurting the ventricle, why intervene at 50 also?
What ventricle?
No, as long as it is not hurting the left ventricle.
Yeah.
Because with the gradient, you're going to have left ventricle hypertrophy dysfunction.
Yeah.
So ventricle is normal, it is not too much hypertrophy. Will you not accept more?
Yeah. Sometimes. That's the reason why before last slide, so I showed the condition of the left ventricle, size and function. The size and function is very important together with thickness, hypertrophy.
Yeah.
But if the ventricle function is decreasing at the time, pressure gradient is decreasing.
Yeah.
So very important, keep the left ventricle function after the operation and during a follow-up period. I think so.
And what was the size of the mechanical valve you put in that 3-year-old patient?
So we are having just the smallest one is 16 millimeter in diameter.
16?
16. In Japan, and usually in the world, I don't know. So
16,
now,
which value, ATS or?
ATS, 16. But cuff size is around 19 to 20.
And you don't get the Onyx valve?
Onyx from 19.
So you get it? Oh, yeah.
Yeah, so usually to make
Onyx is from 17 or 19?
To set 19.
You don't give 17?
No.
So then that will be too big.
Yeah,
the reagent comes in small size. The central reagent is available, I think, in 16.
You are having the 30?
No, yeah.
There's no.
The reagent is also good valve because it comes in 17.
Legendary, valve the condit? No. Regent the small one?
That's and the effective orifice area of
The reagent valve of the SGM.
The effective orifice area of a reagent is more than a 16 ATS.
That's 17, and outside diameter of the cuff is 19 to 20, almost same.
No, but it's supposed to give less gradients. The effective orifice area is very high.
Height is so small.
With a Kono procedure, it is always play around with the size of the valve.
But not so different. Yeah, thank you. Oh, yeah. Almost finished.
Thank you, Dr. Sakamoto, for your presentation. It's very nice to see this operation. So, since the neonatal ROS procedure is very high risk, what is the age that you recommend to do the ROS procedure in this type of the patient?
Well, difficult to say. So, neonatal ROS. Today, so yes, not stuck. So bone stance is not here, but he prefer the neonatal ROS. And I presented this aortic valve repair in neonatal period in front of the both sons, and he recommended again ROS. I try to make aortic valve. That's my response. It's okay. Very sorry. So maybe I can. So I have also two neonatal ROS, but one died because of the EFE and carotid cushion elastosis, even on the neonate with neonatal ROS. And at the time, I checked the EFE inside the right ventricle during the ROS operation. However, I could not find out this patient has a severe EFE or not. Translucent, not white, during the neonatal period. So, in my sense, it was difficult to distinguish which one has EFE severe. So, that's the reason why.
The other problem with the neonatal ROS is that your incidence of reoperation on the RVOT will become too much.
Yeah, of course, the neonate.
Of 8 or 9 size.
We don't have a good material of the
RVOT. By the time you're 6 months or 1
RVOT.
year, you'll operate for the right side. And then by the time the child is 2 years, he has another reoperation. Then by the time he's 10 years, he has another reoperation. So it keeps on going.
Yeah.
And for babies who are 2.5 kilos or 3 kilos, you will not have a conduit for the RVOT.
Yeah.
So then you do something like Dr. Jonas' group, you will use a femoral vein homograph or something.
Homograph.
Yeah, femoral vein homograph because they've got some vials. So
Even homographs,
or you end up
deterioration is
with
faster. Yeah, anyway, so we don't have much homograft in Japan. Thank you very much for attending.
Less presentations and more discussions.
Yeah.